Good day, our dear listener. Today, we are going to discuss a fetal and maternal morbidity. That is anemia in pregnancy. This is a global health problem affecting almost 50% of pregnant women. Imagine that! Usually, pregnancy itself is the cause of anemia because of the increase in blood volume and fetal demands. That is normal. However, it is not normal anymore if we left it untreated. So, be ready with your ears as we are ready with our mouths to impart our knowledge to you about anemia in pregnancy.
So, what is the definition of anemia when it comes to pregnancy? Anemia in pregnancy is a condition in which blood does not have enough healthy red blood cells to carry oxygen to the tissues and to the baby. Having too few red blood cells makes it harder for blood to carry oxygen or iron. This can affect how the cells work in nerves and muscles. To produce RBCs and hemoglobin, your body needs consistent supply of iron and vitamins. Without that supply, your body won't produce enough hemoglobin to properly carry oxygen to your organs. So, it's common for women to become anemic during pregnancy because they don't have enough iron and other vitamins. So, here are several types of anemia that can develop during pregnancy. We have iron deficiency anemia, folate deficiency anemia, and vitamin B12 anemia. First, we have iron deficiency anemia, which is the most common type of anemia in pregnancy. It occurs when the body doesn't have enough iron to produce adequate amounts of hemoglobin, a protein in red blood cells in which carries oxygen from the lungs to the rest of the body. Next, we have folate deficiency anemia. It is the condition wherein folic acid lacks in the blood. During pregnancy, women need extra folate, but sometimes they don't get enough from their diet. When that happens, the body can't make enough normal blood cells to transport oxygen to tissues throughout the body. So, they are given supplements of folate, which are also called folic acid. And last, we have vitamin B12 deficiency, also known as cobalamin deficiency. It is a condition that develops when the body can't make enough healthy red blood cells because it doesn't have enough vitamin B12. Your body needs vitamin B12 to make healthy red blood cells, white blood cells, and platelets. When a pregnant woman doesn't get enough vitamin B12 from their diet, their body can't produce enough healthy red blood cells. Women who don't eat meat, poultry, dairy products, and eggs have greater risk of developing vitamin B12 deficiency.
Okay, so let's now proceed to the clinical manifestations of anemia. So what are the symptoms of anemia? The most noticeable anemia symptom is fatigue. It occurs because there is inadequate oxygen levels in the tissues that should have been carried by the hemoglobin, and other symptoms may include: first, shortness of breath, or what we call the dyspnea. This is the feeling you can't catch your breath or take a deep breath. Dizziness. This is feeling lightheaded or unsteady on your feet. Fast or irregular heartbeat, what we call the arrhythmia. This is when your heart feels like it's racing or skipping beats. Pounding or whooshing sound in your ear. This is a swishing sound in one of your ears that may come and go. Headache. Iron deficiency anemia and anemias caused by low hemoglobin may cause headaches. Pale or yellow skin. Your skin color may be paler than usual. Chest pain. This may feel like something is pressing on or squeezing your chest. Decreased hemoglobin, of course. A patient with anemia has hemoglobin levels between 9 to 11 grams per deciliter. Tachycardia. The heart compensates for the decrease in oxygen by pumping out more blood so it can reach peripheral tissues in the body. We have dyspnea. Difficulty of breathing occurs because of the decreased concentrations of oxygen in the blood. Hence, with decreased hemoglobin that serves as a pigment in red blood cells, the patient may become pale because of the lack or decrease in the pigment that is hemoglobin. That concludes the clinical manifestations of anemia. Let's now proceed to the next reporter, please.
So moving on for the assessment and diagnostic findings of anemia in pregnancy. So the most important factor in the diagnosis of iron deficiency anemia is through laboratory testing. The classic laboratory findings of iron deficiency anemia include a decrease in, first and foremost, we have the hemoglobin level, the serum iron concentration, the serum transferrin saturation, the serum ferritin level, and as well as the increase in total iron binding capacity. So moving on for the diagnostic of anemia in pregnancy. So during the first trimester, so if the patient has more than 30 grams per liter in serum ferritin together with an hemoglobin concentration of more than 11 grams per deciliter, and then 10.5 grams per deciliter during the second trimester, and then 11 grams per deciliter of serum ferritin during the third trimester of pregnancy, then that may indicate that the patient has anemia during pregnancy. Okay, so to determine the presence of anemia, a number of hematologic studies are performed to determine the type and cause of anemia. So this includes, first and foremost, we have the blood studies. So on initial evaluation, the hemoglobin, hematocrit, reticulocyte count, and RBC indices, particularly the mean corpuscular volume and red cell distribution width, are taken to assess the presence of anemia. And then we have iron studies. So examples of iron studies are serum ferritin level, total iron binding capacity, percent saturation, and ferritin, as well as serum vitamin B12 and folate levels are all useful in diagnosing anemia. Last but not the most, we have the CBC values. So the remaining CBC values are useful in determining whether the anemia is an isolated problem or part of another hematologic condition. May I call on the next reporter, please?
So now we're going to discuss medical management of anemia in pregnancy. First is we have the mild to moderate anemia. Physicians will usually treat it with a daily prenatal vitamin or iron supplement. This gives the pregnant woman's body healthy amounts of iron, vitamin B12, and folic acid. Doctors may also suggest adding more foods that are high in iron and folic acid to your diet. For example, lean meat, turkey, or fresh good vegetables like spinach. Next is we have the severe anemia cases. So pregnant women may need a blood transfusion or IV iron therapy. So IV iron therapy should be the first option in the presence of severe anemia and risk factors and in emergency situations, because IV therapy is more effective and rapid than the oral therapy for resolving anemia.
Let us go forward with pharmacologic therapy for anemia in pregnancy. Since 3 types of anemia are mentioned a while ago, I will state the medications for each. For iron deficiency anemia, we have iron supplements. This is used to treat or prevent low blood levels of iron, and especially when the amount of iron taken in from the diet is not enough. However, if you have a history of gastric bypass or small bowel surgery or are unable to tolerate oral iron supplementation, you might need to have iron administered through intravenous administration. Examples are ferrous gluconate, ferrous fumarate, ferrous sulfate, and ferrous bisglycinate. The recommended intake is 27 milligrams of iron per day. Next, for folate deficiency anemia, we have folic acid tablets. This is to help a baby's brain, skull, and spinal cord develop properly in pregnancy and to avoid development problems called neural tube defects, such as spina bifida, where a baby's spine and spinal cord does not develop properly in the womb, causing a gap in the spine. We don't want that to happen, of course. So, it is encouraged for mothers who have this type of anemia to take 400 micrograms of folic acid tablet per day. Lastly, for vitamin B12 deficiency, we have parenteral B12, specifically intramuscularly. This is the recommended form of treatment for B12 deficiency. This is to have a lower risk of giving birth to a baby with a potentially disabling or fatal birth defect, and also to avoid anemia since vitamin B12 helps make red blood cells and proteins. Examples for B12 therapy are hydroxycobalamin and cyanocobalamin. This is taken 1,000 micrograms every 4 weeks. For the next reporter, Miss Krisha.
During pregnancy, a woman may develop a slight expansion onto the blood volume than the normal RBC count as the body prepares for the catering of the growing uterus inside the mother's womb. It is called a pseudoanemia of early pregnancy, which is part of the normal changes in the woman's body. True anemia, however, occurs as a complication of pregnancy. As to why I am here to discuss to you all the nursing care management for pregnant women who have an anemia. First, nursing care management is to provide client and family health teaching. In here, as a nurse, we need to discuss on using iron supplements and increasing the pregnant mother dietary sources of iron as indicated. So the next one is to encourage the mother to monitor hemoglobin level. So this is to evaluate the physical status and as well as the anemia, since we all know that severe iron deficiency anemia during pregnancy can increase the risk of premature birth. That's why we must encourage them to always monitor their hemoglobin level. Third one is to encourage the client to eat foods that is high in iron and as well as in folic acids like green leafy vegetables, fish, meat, poultry, and as well as eggs. Another nursing care management is to emphasize diet high in fiber and fluids to avoid constipation, which is a side effect of iron intake or deficiency. Fifth nursing care management is to encourage the mother to take foods high in vitamin C for iron absorption. Basically because some pregnant women do struggle with absorbing iron. As to why it is important that we encourage them and instruct the pregnant woman on when and which foods to eat to increase absorption. We must also take note that it is easier for the body to absorb meat and seafood iron-containing products. Moreover, vitamin C can help with the absorption of iron when taken with a meal. Another nursing care management is to encourage the mother to take prenatal supplements. Pregnant patients should be instructed on the importance of taking prenatal vitamins which contains iron and folate. So these vitamins, they are very essential for keeping a healthy pregnancy and preventing birth defects. Next is to teach the client to watch out for signs of preterm labor. Another nursing care management is to observe and to monitor the fetal well-being and fetal health by first is the ultrasound at 16 to 24 weeks to assess for intrauterine growth restriction. Next is the non-stress test bi-weekly beginning at 30 weeks. And then lastly is the blood flow velocity to measure blood flow to the uterus and to the placenta. Lastly, it is important to allow the client to rest as much as possible and provide emotional support. So that's it for our discussion about anemia in pregnancy. I hope that you find this discussion very helpful. Thank you for listening. Also, if you have queries, don't hesitate to ask us. Again, this is the Group 1 of Jean J. Thank you. Bye!